Good day and welcome to the third part of our lecture series on sexually transmitted infections. And during this third part, we will discuss mainly a case of female vaginal discharge. And we will try to differentiate between cervicitis and vaginitis and the approach to the diagnosis and treatment. So I am Teki Apalata. I am a specialist in clinical microbiology. So let's look at this third part on vaginal discharge syndrome. Okay. So let's start with this clinical case of a 19-year-old female patient with the complaint of a vaginal discharge. So this patient comes to you. She's 19 years. She says that she is experiencing vaginal discharge. Okay, so this is a 19-year-old. She is a sexually active female. She presents to your office with the complaint of a yellow vaginal discharge, okay, and intermittent postcoital vaginal bleeding. So for the past 1 week, what it means that it's time to time after having intercourse, she can see that there is a bit of vaginal bleeding, for the past 1 week. She otherwise feels well. Her blood pressure is normal, 120/60, and the temperature is normal, it's 37 degree. So on examination, you found that there is a purulent discharge visible coming from the endocervical canal. So this is on examination. You see that there is a purulent discharge. So you can see here, it's really coming from the endocervix. Okay, so it's really a purulent discharge coming from the endocervical os. So you use a PropTech swab, you collect a specimen, and you also collect vaginal fluid for wet preparation. You send it to you can do a wet preparation, you put on the slide, and you also have cervical swabs for testing that you can send to the lab for testing for gonorrhea and chlamydia infections. And you note also a bit of bleeding at the cervical os during the process. So on clinical examination, one thing you can also do is what we call the bimanual exams, and during the bimanual exams, the patient complains of tenderness, above cervical palpation, because when you do it, you are also at the same time do the palpation of the cervix, but the patient denies any uterine or adnexal tenderness. So there is no tenderness during that bimanual exam concomitantly with cervical palpation. There is no tenderness. Okay, so at least that's a very good sign. But the wet preparations, you do it, you check for the pH of the vaginal fluid, you found that the pH is 5. So usually we have said that if the pH is from 4.5 and above, you can, with a high pH, so you can already exclude the possibility of candidiasis. And even if you see the type of discharge you see here, it's completely excluding the possibility of any vaginitis. So this is coming from the endocervix. So it's mainly exclude other causes of vaginitis already. And the pH supports that you exclude the possibility of the other cause of vaginitis with a high pH, that is bacterial vaginosis. You can exclude that. And the amine order test it's also negative, so it excludes the possibility of Trichomonas vaginalis. You have 20 white blood cells per high microscopic field. You have no clue cells. Clue cells are specific vaginal epithelial cells that are covered by large amount of anaerobic bacteria. So it's a suggestive of bacterial vaginosis. So and there are no trichomonad or pseudohyphae seen. So all this, what it means is that there is no candidiasis, there is no bacterial vaginosis, there is no Trichomonas vaginalis infection. So you rule out all causes of vaginitis. The pH is high, it means that, and with the physical examination, you can confirm the possibility of cervicitis. So the only possibilities you have now, it's either it is Neisseria gonorrhea infection or Chlamydia trachomatis infection in this woman. Okay. So the KOH, 10% KOH on vaginal fluid shows a strong fishy odor. Now, this could make you think of infection due to bacterial vaginosis, but mainly Trichomonas vaginalis with the fishy odor. But these signs, if you have it, it's really less sensitive. Now, with the presence of other signs that are absent, so it does not really support the diagnosis of any vaginitis. So what is the likely diagnosis? The likely diagnosis is that it's a case of female vaginal discharge that is high likely to be a cervicitis. So this is a case of cervicitis, and the likely etiological agents can be either Neisseria gonorrhea or Chlamydia trachomatis infection. And of course, your first line of treatment, if you have to approach a case of cervicitis, we say that the causes of cervicitis are the same like the causes of urethritis in male patients. So you can use a third generation cephalosporin 250 milligram single injection IM, and you can combine that with 1 gram of azithromycin single dose. So to treat as a first line empiric treatment. So when you suspect cervical disease, discharge of cervicitis, it's mainly caused by Neisseria gonorrhea or Chlamydia trachomatis. When the discharge is a vaginal discharge, it's called by Trichomonas vaginalis, that is a STI, and a non-STI pathogen like Candida albicans and bacterial and Gardnerella vaginalis that causes a condition called bacterial vaginosis. So let me just try to repeat this to make you understand this very well. When you receive a female patient who complains of having a vaginal discharge, the first thing you have to do during the examination is to find out if the discharge is from the vaginal canal or it's originated from the vagina or it's coming from the cervical os. So what you have to do is to place a speculum, okay, put the woman on a gynecological position, place the speculum, and take a swab with the gauze, take the gauze, try to wipe, all the excess discharge that is there to try to establish if the discharge is coming from the cervix, and look also the signs of inflammation on the cervical os area, or to try to see if the problem is at the vaginal area. So the first thing is to establish the difference between whether you are dealing with a vaginitis or cervicitis. Okay. Then if you are dealing with cervicitis, then you need to know what are the causes of cervicitis. So the causes of cervicitis, it's then Neisseria gonorrhea or Chlamydia trachomatis. But if it's vaginitis, then you can think of Trichomonas vaginalis or Candida albicans or Gardnerella vaginalis that causes one of the causes of a condition known as bacterial vaginosis. Okay, so that's the first thing that you have to establish. Okay, then how do you approach the treatment for these conditions? Okay, if you are thinking of vaginitis, vaginitis, that can be a vaginal candidiasis or a vaginal or bacterial vaginosis or infection due to trichomoniasis, then you can put this patient on metronidazole oral, 2 grams as a single dose. Then you can also, that covers, this metronidazole covers either Trichomonas vaginalis or bacterial vaginosis. Then you add clotrimazole vaginal pessary, 500 milligram, that will be inserted into the vagina, okay? That covers candida infection. Or you can use clotrimazole vaginal cream, okay? So alternatively, if there is no response, you can use metronidazole oral 400 milligram 12 hourly. So 400 milligram twice a day for 7 days. So if there is still no response, you can refer to a specialist where we are going to do more extra tests to try to find out the cause. But if that's when you are suspecting vaginitis, but in a case of this patient, for example, where we are suspecting cervicitis, the causes, as we said, can be Neisseria gonorrhea or chlamydia. Then you give this patient ceftriaxone, intramuscularly 250 milligram, a single dose, a single injection. Then you can give this patient azithromycin 1 gram as a single dose. Just to be sure, if you are not certain that the discharge is strictly coming from the cervical os, you are afraid of missing any vaginitis, any vaginal infection, then you can also, in this combination, add metronidazole 2 grams as a single dose, okay? But if you have a typical card-like discharge with erythema and itching and or excoriation are present, where you can suspect also candida, then you can also add clotrimazole, vaginal pessary or vaginal cream, just to ensure that you don't miss a condition of a candida infection. So that's your approach to a patient with a vaginal discharge. So the first exercise will be to try to ensure that you are able to separate vaginitis from a cervicitis. If you think it's truly a cervicitis, you give ceftriaxone and azithromycin. If you are unsure, you add metronidazole to cover causes of vaginitis, and you can also add clotrimazole pessary or cream, vaginal cream, just to ensure that you cover also a possibility of candida vaginitis. Okay, now let's go back to our patient, the 19-year-old female who came to you with vaginal discharge, okay? Now, 1 week later, the patient returns to you complaining of low abdominal pain. Remember, this was not there initially. Now she has low abdominal pain, she has fever, chills, and malaise. She also complains of nausea and multiple episodes of vomiting in the past 24 hours. Now you can see that the condition of this patient deteriorated. It becomes more complicated, okay? So on physical examination, there is now a bilateral adnexal tenderness. Remember when you did a bimanual examination initially, she did not have that, but now she has adnexal tenderness, and there is still a mucopurulent cervical discharge and cervical motion tenderness when you try to move the cervix. she feels pain and she has a temperature of 40. Okay, so this condition becomes more complicated. The last menstrual period was 4 weeks ago, and her pregnancy test is negative. So it means that you exclude the possibility of pregnancy. So she is not pregnant, this lady. She admits to being sexually active, but denies having unprotected sex with the current boyfriend. In addition, she is currently not using birth control. Okay, so what is the likely diagnosis? The likely diagnosis of this patient is a condition that we call pelvic inflammatory disease. It's what we call PID. PID, that is pelvic inflammatory disease. So it's a serious condition. The likely etiological agent causing this condition, it can still be the same Neisseria gonorrhea, chlamydia trachomatis, but it can also be due to other anaerobic bacteria. It can also be due to Trichomonas vaginalis and other mixed anaerobic bacteria that are also able to create an ascending infection, okay, as the cause of pelvic inflammatory disease. So this patient did not respond to the treatment that you gave her. So the first line treatment, we will see. So let's look at this condition. Clinical considerations is that it's an ascending infections. It's usually caused by mixed vaginal and cervical infections. And you also need to make the difference between mild PID that you are going to manage this patient as outpatient, or severe PID, where this patient needs to be admitted and managed inside the hospital. So you cannot send this patient home. And you need to exclude the possibility of puerperal sepsis. Maybe this patient had, but this patient told you that she had her last menstrual. She saw her last menstrual period 4 weeks ago. The pregnancy test is negative. You just need to ensure that she did not give birth or had try to get the pregnancy terminated, and now there is a septic condition following that, or you exclude the possibility of ectopic pregnancy as well. You need to ensure that all those are excluded. Then you also need to know the exact etiological agent causing this condition by doing a number of tests and the antibiotic susceptibility profile, since the patient failed the initial treatment that you instated. So let's look at the approach to acute pelvic inflammatory disease that we call PID. Okay, so the diagnostic criteria for PID, the first one is that complaints of pelvic or lower abdominal pain, and we saw that this patient complained of lower abdominal pain, and the cervical motion tenderness or uterine tenderness or adnexal tenderness during the physical exams, okay? And the other supportive criteria, it's a high fever above 38.3 degree, cervical or vaginal mucopurulent discharge. There are the presence of white blood cells on wet preparation. There is elevated CRP, especially for acute infection. You look more for CRP, and documented evidence of Neisseria gonorrhea or chlamydia trachomatis is found. Usually you have to take the discharge, do a PCR, and try to document the evidence of any of these infections are supportive criteria for pelvic inflammatory disease. So this is an ascending infection. Remember that it's a sexually transmitted infection. The infection, this is the cervical os. All this is the vagina, and this is the cervical os. So the initial infection was that the patient came initially, she has a cervicitis. Then from there, the infection progressed toward the fallopian tubes, toward the fallopian tubes. And now it's a pelvic inflammatory disease here, So all this is now infected, So it becomes now a very serious disseminated infections. Okay, so sometimes it can be a Thibaut ovarian mass, with a pelvic inflammatory infections. Okay, so it's both, most of the causes can be both causes of cervicitis and vaginitis. Okay, so the causative agent can be both Neisseria gonorrhea, Chlamydia trachomatis, mixed anaerobic infection, and sometimes other bacteria that are not STIs, that do not cause STI, like your gram-negative and gram-positive, like Streptococcus, can also be found there. So sometimes the patient will have a Thibaut ovarian mass, and sometimes it can become an abscess, a Thibaut ovarian abscess that can be found in this patient. So the approach here is that you need to establish, you take a good history, gynecological history, a good exam of abdominal and vaginal exam, exclude also emphasize on HIV testing, try to make sure that this woman is not pregnant, there are no missed period, there is no recent history of delivery, because you need to exclude the possibility of puerperal sepsis, termination of pregnancy or miscarriage, you try to exclude that. Abdominal guarding or rebound tenderness during physical exam, there is no vaginal bleeding, no abdominal mass or fever above 30 degrees. So if you establish any of this, then you really need to refer this patient to a gynecologist, for appropriate management. But if the patient is severely ill and there will be a delay in referral, you need to put, of course, put an IV line, put this patient on ceftriaxone 1 gram IV. So this is now IV 1 gram, not like what we did before, intramuscularly 250 milligram of ceftriaxone, but here you now give IV intravenously 1 gram. You increase the dose of ceftriaxone. And if this patient can take treatment orally, you also add metronidazole 400 milligram oral. You can give also ibuprofen oral 400 milligram 8 hourly, for the pen, because the pen might be too much. But if none of these is established, you look at the low abdominal tenderness with or without discharge, you do a urine analysis, and here you can still give ceftriaxone IM 250, you add azithromycin and metronidazole, you give something for pen, then you review the patient after 2 to 3 days, but it's better you refer this patient to a gynecologist. A PID case should be managed, with the patient admitted, and it should be managed by a gynecologist. Other guideline for the management of PID, the first line PID, especially for inpatient regimen, you can give IV cefotetan or IV cefoxitin plus doxycycline, or you can give IV clindamycin plus combined with IV gentamicin. Okay, but as an outpatient regimen for mild PID, you can give IM ceftriaxone plus oral doxy with or without oral metronidazole, or IM cefoxitin and oral probenecid plus oral doxycycline with or without metronidazole. So those are different guidelines that you can follow in managing a case of PID, pelvic inflammatory disease, whether it's moderate or it's severe. For all severe cases, need to be admitted. Now, let's look at a case of vulvovaginal candidiasis. Now, vulvovaginal candidiasis, I said, with bacterial vaginosis, are not sexually transmitted infection, but they are among the commonest causes of vaginitis in women. So 2 out of 3 women or 3 out of 4 women healthy women will develop vulvovaginal candidiasis at least once during their reproductive age. Okay, so 5 to 10% of women will develop what we call recurrent vulvovaginal candidiasis, and that is the most concerning condition, recurrent vulvovaginal candidiasis. Recurrent vulvovaginal candidiasis is defined as the occurrence of 4 or more episodes of vulvovaginal candidiasis per year. 4 or more episodes. It becomes really a terrible condition to deal with. There are anecdotal reports that are linking recurrent episodes of candidiasis to HIV-related immunosuppressions, okay? But there is also what we call primary recurrent vulvovaginal candidiasis. It means that it's idiopathic. The cause, the underlying mechanism, it's not well known. Versus secondary recurrent vulvovaginal candidiasis, that is maybe HIV-associated immunosuppression or any other reasons, okay? So why do we care today about vulvovaginal candidiasis? It's mainly because of recurrent condition that affect 1 out of 15 adult women, and it really costs a lot of money to manage those cases because it becomes a chronic disease. It is costly to manage, so it becomes a serious infection. So the average patient suffers from 5 to 6 episodes per year, each lasting about 1 week. And in severe cases, there is acute inflammatory symptoms. It really affects the relationship between partners, you know, so it's really a serious condition. And you can see a typical classic presentation of vaginal candidiasis. You see curdy, cottage, whitish discharge. You can see it there, you know, and it's itching, and you can see the woman is scratching. So this is a typical presentation of Candida vaginitis that you can see. Okay. Now, the pathogenesis of recurrent vulvovaginal candidiasis, it's thought to be HIV-induced, but not all women with recurrent vaginal candidiasis are HIV infected. But there are also a possibility of disbalances between the Th17 and regulatory T cells in balances, you know, or dysregulated immune response, you know, that are also found to be involved. Or there is also a role of hypersensitivity, IgE mediated hypersensitivity responses, or toll-like receptor 2 mediated responses that create, you know, problems in terms of host immune responses to Candida infections. So there are a lot of theories. But the most important things is, how do you manage patients with a recurrent vulvovaginal candidiasis? Remember, simple vaginal candidiasis, we say that you can have clotrimazole pessaries, you know, vaginal pessaries, or you can have vaginal cream. But when the condition is recurrent, it becomes a bit difficult, okay? And most of cases of recurrent vulvovaginal candidiasis are caused either by Candida glabrata or other non-albicans Candida. They are found in 10 to 20% of cases, okay? So you start to manage recurrent cases of VVC by what we call an induction phase. Induction phase will last for 7 to 14 days, where you use topical azole treatment or oral doses of fluconazole every 3rd day until the patient will experience any remission. So you can use either topical fluconazole or oral fluconazole for 7 to 14 days. until the patient will experience any mycological remission. Then you put the patient on suppressive maintenance phase, that is oral fluconazole again weekly for 6 months. Every week for 6 months. That's what we call suppressive maintenance phase. Then non-albicans vulvovaginal candidiasis and severe vulvovaginal candidiasis, you can use a non-fluconazole azole regimen because they don't respond to fluconazole. You can use a non-fluconazole azole regimen, or you can put the patient on a 600 milligram boric acid. That comes in a gelatin capsule for 2 weeks. So you can also use that as part of the treatment. So this is how you can approach a case of a woman that comes to you with a female with a vaginal discharge, and how you can try to navigate around that case to find out whether it's vaginitis or cervicitis and how you can manage its condition. So follow us on the fourth part of this presentation on a sexually transmitted lecture series, where we are now going to discuss condition that we call genital ulcer disease. Genital ulcer disease. So we will have follow us on the next lecture series. Thank you. Goodbye.